one more. And so I promise I will try to dump this down to about an hour and a half, 2 hours, get you out of here with these two. So no, actually, I love what Robert just presented because I'm going to hit some of those same keys with the business of sleep. So to give you a little bit of background, I'm Mark Waugh, I've been president of the Accounting Society, but I've been for the last 3 or 4 years. I've been involved with the Sleep Society for about 6. I started out in sleep back in 2003, but now I currently work as the director of implementation and business development. So it's and also business development and implementation. So I get to go out and talk with hospitals and help them understand their current processes and make those processes better. Look at the sleep lab. We need to get away from the perspective of, hey, we see a patient, we send them home. We do a sleep study, we send them home. We need more of a holistic approach, kind of like what Robert was sharing, to really engage these patients and grow the sleep business for that hospital. So I'm gonna probably skip through some of the slides pretty quickly, especially this next one that's coming up. I'll tell you why here in a second. So the opportunity of sleep, to understand the size and cost of the market, the growth opportunities, the targets, important patient expectations, and way to improve that overall experience. And I'm going to skip past this one pretty quickly because Robert had this one in his slide about the prevalence of OSA. What I found very interesting though is when you go to the hospital, you ask the hospital, and we did this one before the hospital. We asked them, how many of your patients are at high risk? And they're like, and this was just for COPD and just part of it. It's just how many of your patients are at risk? And they're like, we know that data. It's like 20%, 22%. We know it. So we challenged them on that. And we did a study. And so they did like this 3-month study. You know what the actual percentage was? It was 78%. So they're like, whoa, we were a little wrong with that. Sorry. Oh, no worries. So the prevalence of sleep apnea, if you especially look at these comorbid conditions, it just goes up and up and up and up. So approximately 42% of Americans have, 42 million American adults have sleep disorder breathing. 1 in 5 have OSA, 1 in 15 moderate OSA. I mean, these are stats, and it's a huge, huge problem that we have to address. She broke it. Got it. It was still clicked on Zoom. We'll get through some of this. So talking about growth options and support for your diagnostic service plan. So you have the in-center testing, you have the home sleep apnea testing, but there's so many more programs like sleep navigation, like Robert was talking about, post-discharge reduction programs, population health and occupational health, ACO and insurance screenings. How if your hospital is part of an ACO, accountable care organization, go to them and you show them what a solid screening platform in the sleep department could do and how much money they could save. Inpatient programs, direct-to-consumer programs, clinical research programs, therapy services, and remote patient monitoring, which we've heard a lot about this morning. The direct-to-consumer programs. Does your hospital have a Facebook page? Do they promote sleep on the Facebook page? What if you took that screening that Rob was talking about and put it on a Facebook page for your hospital's Facebook page? So we did that, and we saw it went. We were getting in just one little area. We didn't do Facebook posting. We did other marketing material posting just in the office. And we got 30, 40 screenings a month. When we put it on Facebook, guess how many screenings we got each month? 400. because you're at home, right? I mean, we're so used to clicking through Facebook and Instagram and, oh, there's a survey, boom, take it. Oh, there's a survey, boom, take it. What that patient didn't know on the back end of that is an email sent over to the hospital, to the physician's office, and said, this person just took a screen. Here's her phone number. Give her a call. Now the physician can call that patient and go, hey, I saw that you just did a screening on Facebook or at the hospital on our office website. You're at high risk. Let's get you in for a consultation. So when we do that, we need to look at what are the best opportunities for referrals. And so, the prevalence of insurance members, about 4 to 6%. What we kind of see in hospital inpatients, about 24% are at high risk and have opportunities for those referrals. Comorbidity clinics, your diabetes, cardiac, primary care physicians, anywhere, this is where it just ranges, anywhere from 29 to 78%. So that could be your target. Target those clinics where you have a fluctuation of high outcomes and target those with some screening programs. Primary care physicians. Now, has anybody tried to start a program and it kind of looks like this? It's just a mess. Where do you start? How do you work through what's the best pathway for the patient, right? And this is what it looked like in the past. It was just chaos. So we need to clean that up. There's areas to focus to improve patient and payer value. The biggest one, education and awareness. Education is so important, especially for physicians. So we go back to the sleep navigator. If the sleep navigator walks in and goes, hey, you take this screening, we want to see if you have OSA. Patient takes it, oh, yeah, you do, thank you. There's no engagement. That patient's like, I don't know what OSA means, right? But if they sit down and take 10, 15 minutes to explain what obstructive sleep apnea is, how it affects their body, how it exacerbates their conditions, they really educate. And then post-discharge, they're probably on a bunch of medications in the hospital there. I think somebody told me about obstructive sleep apnea. But the follow-up, remember when I saw you in the hospital, we talked about this. Now that you're home, let's really get you set up with a consultation or, that education is extremely important. Do your payer sources understand the cost value of treating OSA? Do they understand how much money they will save? Just to give you a little example, we talked about sleep navigation, post-discharge, readmission reduction. Well, that's great. You can save a readmission. If you save one readmission, that's anywhere from $10,000 to $15,000 for the hospital that they save. That's great. But have they thought about now they can use that bed for a paying patient? They don't have the readmission, but they're not only losing that readmission, they're taking up bed space for patients who they could actually bill for. So there was one hospital in Tennessee that actually did a readmission reduction program, and the CEO took all of the data to understand and kind of base how much savings, like readmission reduction, like $3 million, but he said he thought it was more like $7 to $8 million because of the additional revenue by saving those patients from readmitting. Access. Does your program allow easy and timely access to the clinics? Convenience. Does your patient process, take this into account? How convenient is it for the patient? How easy is it for the patient? Sometimes how easy is it for the physician too, right? Engagement. Do you know your key engagement metrics? Key engagement metrics are extremely important, especially for your sleep lab. So does your reporting show you how many referrals that you got in a month? What referral sources did it come from? How long did it take you to key that patient in and get their first sleep study? How long did it take you to key that patient and get insurance authorization done? How long did it take that patient to get to the CPAP study? How long did it take to score that sleep study? How long did it take for the interpreting physician to interpret that sleep study?
These are all important metrics to understanding your sleep lab so you can guide the care in a direction where it's faster and easier for that patient. And how is your program driving patient outcomes? You know, the pre and post admission rates and cost savings, PAP alternatives. You're following that patient and understanding if they're compliant. Outcomes. So how your program should appear to your patients. You know, we looked at this, and this is what, you know, typically what it looks like for a patient. This is what it needs to look like. A very streamlined process. You have referral resources. You know, you have awareness campaigns for your program. You do the sleep surveys, complete the consultation. You have initial consultation, PSG, interpretation, sleep physicians following up with them, DME ordered. You know, the patient onboarding is set up for therapy and continued sleep coaching and making sure that patient's compliant. It should be simple. Some healthcare business develop strategies to consider for your action plan. So cost effective and understanding patient care is just good business. I'm going to actually skip over some of these. Yeah, okay, I'm going to go straight to the performance metric. So this is one example of a performance metric. So you can break it down per each section and understand. You know, so a perfect example. Do you know how many studies that you're unable to schedule for sleep lab? Does anybody know? One person. Does anybody know why you're unable to schedule those patients? You know, do you have a 20%, 30%, 40% unable to schedule? Is it because you can't get in contact with the patient? Maybe that referring physician needs to help give that patient education so they understand why you're calling them. You know, is it because the insurance denial? And how many of those insurance denials actually converted over into HSTs, which you can do while you're on the phone, getting the PSG. So understanding where your sleep lab is extremely important. Treating sleep apnea reduces overall health costs. Robert talked about this a bit. Short-term disability reduction. This was a study done for motor vehicle driver population, and you know they saw in pre-study, you know that was the first pre-study. After the first year reduction, after the second year, saw even more reduction. Short-term disability, same thing. They saw the biggest in short-term the first year after it. Second year went back up, but it didn't get back up to where it was. Occupational health perspective, you know, treated drivers are almost $6,000 less costly in 2-year saving total. Insurance parent ACO perspective, same thing. Accountable care organizations, occupational health perspectives. There is value in not only diagnosing, but adhering to CPAP treatment for these patients and monitoring these patients. So inpatient post-discharge screening, reducing readmissions, like we were talking about before, and screening. So here's just some stats on this. I like this slide. You can see the primary conditions. And to keep in mind, this is comorbid OSA with insomnia. So this is including insomnia. But each disease state, you can see what the percentages are. And then, you know, 24% of hospital inpatients are at risk for sleep apnea. So like Robert was saying, if you how many beds is your hospital? Somebody's hospital, how many beds? Anybody? Yeah. 402. So 402 beds. You're going to have about 1,300 patients that revolve monthly in and out of that hospital. The 1,300 patients, 24%, 25% will be at high risk. Hospital readmission reduction. So average cost for COPD readmission is almost $10,000. Average cost for a congestive heart failure patient, $15,000. So what a hospital can do is focus in on these 6 conditions. Screen, start small. You know, that elephant, take a small bite, start really small. Take one of these conditions, screen for it, see how the program does, and then open it up to the rest of these conditions. Because these are the 6 primary conditions where hospitals will get charged for admission rates. And that's really where we want to focus on for that hospital. So 1 in 5 Medicare beneficiaries are readmitted within 30 days of discharge. So look at your hospital's payer mix. You know, is it 40% Medicare, 30% Medicare, 70? I saw one hospital is 76% Medicare. So then you consider 1 in 5 of those patients coming back month after month. Inpatient sleep programs. Just like I'm glad Robert mentioned this because this is important. He went through these steps: screen, identify, evaluate, protect, diagnose, treat, and monitor. So I'm just going to skip over these. I just want to reemphasize this is what you have to do with a screening program to be successful. Identify and screen, care plan coordination, monitor, communicate, and track and report outcomes. And I'm going to hit more on report and track outcomes as I talk because you don't know how well you've done with the program unless you can see an outcome, report on that. You can have a sleep navigator screen 500 patients in a month, but if I can't prove that 50% or 60% of those patients have sleep study, then it doesn't support having a sleep navigator. So it's extremely important. Okay, I'm just going to skip because the rest of those kind of ties in, and I want to get you guys out of here in a timely manner, tied in kind of what Robert was already saying. So marketing and branding. Understanding the ways you can enhance marketing and branding strategies, how to better educate, you know, your community, the patients, and drive more referrals. Easy ways to screen for sleep patients. So you have education materials for the community, screening forms, you know, additional screening programs. University of Pennsylvania came out with additional screening programs just to, it's above and beyond just screening for OSA. They're utilizing these tools. Who in here has a smartphone? Pull up your smartphone. Everybody has a smartphone. Has anybody ever seen a QR code? So you can actually zoom in on that and click on it on your phone. Yeah, if you want to. Zoom in on it, it's going to take you to the screening assessment. That's what I was talking about. You can have outside your physician clinics, have signage, have rack cars, have materials in there for every patient to come through. We did this in one hospital, and I told the director of respiratory, I said, do you think they would let us put it in the ER? She's like, yeah. So we put it right in the ER, right behind all of the chairs. And I walked over to the nursing staff and I said, hey, I told them what it was, told them what it was for, and they just were like, oh my God, that's the best thing ever. So now when patients come in, they're to the charge nurse that's seeing those patients, she's like, while you're waiting, you have a short wait at the ER. While you're waiting, click on the QR code and do our sleep assessment. That goes directly back to the physician's office when all that patient go, hey, I just saw that you were in the hospital, you took a screening, you're at high risk, let's get you in for a consult. Patient education. So much material for patient education. Patient education is important, helping them understand why they should be concerned about this, right? Lots of other materials, lots of news articles, utilize that, get your medical director involved. Have him, comment on an article and post it on your websites. Social media campaigns. This is some of the social media campaigns that we did.
and how, posting this on Facebook. They see those images. Well, especially if you got the guy snoring, the wife, if she sees that image, yeah, that triggers a deep anger, emotional response. They're like, take the survey now. So use social media. Resource library. Create a resource library for your physicians. Create a resource library for your patients to be able to access and go to, read about, sleep apnea and other sleep conditions. So some healthcare business strategies for you to consider for your action plan. Know the benefits of maximizing search engine optimization to improve, capture of Google searches. Understand your marketing teams at your hospitals. They understand this. They can help target those. Establish that social media marketing advertising. Work with your hospital, ensure that the sleep ordering process within the EMR is easy. It is being done. It's not optional, like Robert was saying. Determine which determine which hospital clinics support comorbid populations and provide that marketing material. Provide resources for them. I started on one sleep lab. We had it running for a little while, and I went to the director, and I was like, let's go out and talk to some of your referring physicians, and just right around the hospital, some of them are in the same medical complex, because referrals weren't coming in as they should. She's like, oh, that's a great idea. So we went out. We went and saw 10 providers. Guess how many providers knew there was a sleep lab at their hospital? One. Yeah, one of the 10. So it's important to provide, thank you. It's important to provide that education for those physicians. It's important to have resources for those physicians. You need to make it easy for a physician to order sleep study. You have to be in their face. Create clinical workflow with automatic periodic engagement materials. Use what you have. There's lots of emerging technology. Does anybody notice how many companies are popping up all over the place with HSATs and other different technologies? So the PSG, is this a really outdated diagnostic procedure? I don't think so, no. But is it needed every single time for every single patient? Every patient needed in that study? No, they don't. So utilize some of the diagnostic technology coming out. Does home sleep apnea testing always hit the mark? What percentage of studies you perform are HSTs? Look at those numbers. What percentage of HSTs do you have a mail to patient model? Do you send out the home sleep study in mail? You have to send it back. Do they have to come to the lab to pick it up? Think about what your procedures are and making it easier for that patient to receive and do that sleep test. How will that impact, what impact is cost on each of those procedures? How much does it cost to send it out and bring it back? How much does it cost the patient to come and pick it up? Look at those numbers. What will be the impact of disposables? Now you're just sending that once. You use it, you throw it away. Think about these things and how it will better improve, your processes. Home sleep apnea testing. This is just one model. Sleep study intake and scheduling, testing, 24-hour clinical support. Do you have support for that patient? What if the patient gets home with a device and they're like, I don't know what to do. I'm at 3 o'clock in the morning. They're waking up and they're like, oh, everything's off. What should I do? Are they calling you? Are they calling the sleep tech at night to get that support? To make that a successful study? Scoring of data, interpretation of data, and the results delivered. Track each step and make sure it's an easy process. Embrace some of the new technology. There's home PSG, level 2 devices. You have Knox that has one. You have Amnera came out. And it's a PSG at home. Patient actually takes it home, but I've actually tested out and worn one of those devices. It's a little pad that goes on your head, on your chest, on your leg. That's it. And it picks up EEG, EOG, EMG, leg movements, heart rate, oxygen. It's like a mini PSG. Other PAT-based technology, the night owl. Has anybody seen the night owl? It's this big. I think the quarter is bigger. It goes right on your finger. Sunrise, Bell and Ring, Somfit, Sleepama. There's lots of new technology out there. Have you tried this technology in your sleep lab? Have you tested it against other technology? Have you tested it against, say, the 911? Have you tested it against some of these others to see how they work? Let's see here. Let's get that one. So determine how to ensure add value really to your sleep center. That's where we really want to look at. How are you going to bring value to the sleep center, and how are you going to make the patient experience easy, and how are you going to make the referring sources want to refer to you, make it easy for them. Know the benefits of providing a lower cost procedure that ensures the best result. If you have a 32-year-old male who runs 5 miles a day, don't bring him into the sleep lab, send him an HST. He still might have sleep apnea, but he doesn't need to come to sleep lab. No. Maximize your CPT codes when appropriate. So there is, for like, an example of this is a home sleep study. So does anybody know the 2 codes for the home sleep study, diagnostic codes? 95806 and 95800. In most of the cases, the 95800 pays more money than the 9506, 00 over the 806, because the 00 has total sleep time. So, what if your physician just wants to use a 95806 like the 91 because he loves the flow, he wants the flow, he doesn't want to pack technology? What do you do? How can you get more money for reimbursement? Partner with a company who can add total sleep time to do that 95800. The 9806, the 91 device. There's companies that can add total sleep time, and now you can bill at a higher reimbursement. So understand, know those codes and what you can do that. Streamline your process. Don't duplicate processes and automate anything that you can. How much time do you spend doing on a task, and is there a better way to do it? Determine ways to add value. Improve HST to PSG ratios to lower, the payer's diagnostic costs when appropriate. Improve patient experience with better outcomes. Improve treatment options and deliver success. There's so many opportunities, I think, right now in the field of sleep and growing the sleep lab. We just have to get out there and do it. So I get you out of here. So any questions? Yes.
So what is the follow like, yeah. So that tunnel, like that, like what's that one? Anybody else getting that? So we do it where they come in and get
Yeah.
back. But anybody like getting the they'll like
Yeah, she just mentioned back on the feet.
okay.
Back on the feet. And come talk to me after. We talk a little bit. But yeah, it's, the mail order model can be a difficult process to fine tune, just because, patients, I think patients like take these devices sometimes and mount them up on their wall or something, right? But you pick up, they're the same way, these devices pick up too, so. It's just something you have to evaluate, I think, and understand how many devices we lost on each side, or doing disposal options. Any other questions? All right, well, on behalf of the Carolina Civic Society, thank you so much for coming out and enjoy each.
Yeah, so we might not, yeah.
You know what I'm saying?
I'm trying to.